Voilà, depuis 10 ans, depuis 2007, nous n'avions jamais eu de
Well,
problème de ce
since
type.
2007, we never had such problems before. To start, okay, the translation from French into English will work since the first speakers are French-speaking ones. Eric Strain will be able to listen to the translation of the speakers, of the French-speaking speakers, right? I am being said that for Spanish translation, it also works, and translation from English into French will be probably working once Eric Strain will have the floor. Yeah, it should be working from any language into English or into French, or whether it is into Spanish, right? So we're sorry for this delay, this debate. Very quickly then, so this debate devoted to psychedelic. We'll have a very brief and introductory words. Zoé DUBUS from Paris, she is going to tell us about the history of psychedelic and the treatment of psychedelic drugs.
No? But the English is okay? Or?
Yeah, in English, I hope you can hear us. We are translating, we are interpreting from the floor into English.
Okay. So no. Does it work in French? Alors me dit parfois. Alors bon.
They tell me sometimes. Well, we're gonna start. We're gonna solve it very fast. Zoé DUBUS first. The second speaker will be Joël BOCKAERT from Montpellier. He will present the action modes and the effects very quickly. And then Daniele, ZULLINO, professor of psychiatry in Genève. He is the one with the largest experience in the range of psychotherapy amplified with psychedelic drugs. 10 minutes, and afterwards we will have some time for discussion, and if necessary we will be able to extend this discussion a little bit in time. Yeah, Eric, is it okay? Can you follow? Yeah. Last but not least, Jean-Michel DELILE will be moderating the debate, psychiatrist, anthropologist, and addictologist. And he was a long president of the Federation of Addictions. He is a well-known specialist also in psychedelic drugs. He accepted to moderate this discussion. So, yeah, best wishes for this second round. Thank you very much, Jean-Pierre. Jean-Pierre proposed me to moderate this roundtable. I accepted immediately for three reasons. The first, because Jean-Pierre is a friend of since more than 50 years. And we were at the Hôpital Charles Perrin in Bordeaux. He was assistant director, and I owe him all respect. The second reason is that we have an amazing panel which has just been presented with BOCKAERT professor, one of the highest specialist in the neurobiology of receptors, G protein, serotonin. He has worked a lot on hallucinogenous substances. I invite you to read his book. Zoe DUBUS, an historian with contrasted experiences in medicine. At the beginning, it was like panacea drugs. Now there is a form of rehabilitation. And Daniele ZULLINO is extraordinary because we hadn't met one another again for 20 years. He had come to the Journée de la NIT, the parents of the Federation of Addictions in Saint-Étienne. He is one of the greatest specialists on the subject in Europe. And we will have our friends Eric Strain, a worldwide authority. He works at the Johns Hopkins addictions, drug addictions and non-drug addictions, and he will bring some light and prudence vis-à-vis the extension of these psychedelic drugs that we know they can have some effects to be controlled in certain cases. And the actor of La Réduction des Risques, Alexandre PEYRE, we met in the therapeutic community in the French Guiana, and through all the works he has led to help young people who had experienced bad trips. So this is to tell you that this is an amazing panel. And the third reason which I accepted is that it is a subject that I leave from the bottom of my heart, because I am also anthropologist. I've worked in Western Africa, the hospital of Dakar, also in Cameroon and Mali. And I was touched by what Jean-Pierre said, the need of privileging the reason. I learned that we have to pay attention to traditional knowledge to create spaces for dialogue, room for dialogue, through an experience of mutual understanding. This allows us to have a more favorable impact on the involved people. This was, well, the subject of the shaman and medicine in some books. And Biarritz also, 20 years ago, we were discussing with Michel Reynaud of the emergence in France, the emergence of drugs of nature, Natura, LSA, Salvia, Divinorum. Well, we realized that there was a return to some substances taking which who were searching for a double biology, and also within the context on working on themselves, linked to the discovery of an initiatic travel. Some went to Brazil or Guyana to discover ayahuasca. It was at the same time in the States, in Switzerland, in England, where all these products were analyzed and searched for. There was a first stream of enthusiasm, a second one of rejection, well, because there were bad trips and induced psychotic troubles, disorders, as well as a rebel population, a population that was revolting against the power at that time, the prohibition of doing research. And fortunately, all this can be relaunched, provided that the efficiency conditions are interesting. I will invite Zoe to address her speech about her historical view of what has just been said. Thank you all. Thanks to the organization of ATHS to present you my works, I will give you a huge panoramic of all this with short attention on other contexts, but we have to tell you about our situation. What are psychedelic? Well, just to tell you about the substances, and Mr. BOCKAERT will present the effects. These substances, there are others which have similar effects like ketamine, but they do not have the same mechanism of actions concerning the receptors of serotonin. Psychedelic term will evolve because it brings an imaginary link to the hippie world, which is not too legitimate for contemporary science, but there are substances which are excluded from this classical classification. It was invented in 1956 by an English psychiatrist. They think about a new world because the available terms hallucinogen, psychotomimetic, for example, refer to effects perceived as pathological. So we imagine that these effects were mimetizing the psychotropes. So LSD more used in medicine. It refers to these pathologic effects, not too efficient, and psychedelic was chosen. The exchanges between Huxley and Osmond were published in a book recently. Why psychedelic? Revealing the soul. Aldous Huxley based her works on Henri Bergson in France. The role of the brain is reducing the number of infinite data we receive from the world. It is too much to work. He said that it was a reductive valve. Sorry, the sound is a bit chunked, and now it seems it has disappeared. Well, comes back. So it is very difficult to date it. The psychedelic, they are from plants which are perishable. We will find ancient marks, and there was also the period of colonization of the Western world, and we lost some knowledge that we will never find again. There are some theories, some philosophers that say that it would be the lacking part. That's what you can say on this picture, peinture d'Alex Gray. This monkey that would be eating hallucinogenic mushrooms. These theories are interesting for some thought hypotheses.
And here you can see the shaman, or this is what we believe is a shaman, and he's surrounded by mushrooms. There are many criticisms around this kind of interpretation, but we know that these substances have been used for thousands of years for certain civilizations on Earth, and colonization had a very important impact on this. And there were some colonizers, European colonizers in Africa, that consider this as diabolic practices. And they destroyed books that had gathered all this knowledge. And, well, we have no trace of this kind of use. And there can be usages that are therapeutic, but this can coexist with ceremonial usages and also other usages related to leisure. So the interest of the Western work for psychedelic substances comes in the 19th century. They're the first nations in the US and in Canada that make ceremonies out of a cactus called peyote, which grows in Mexico. And these ceremonies are aimed at showing more cohesion amongst the people of a certain ethnic. And these ceremonies as well are a way to fight against alcoholism that is causing lots of havoc in these communities. So there are ceremonies, these ceremonies that are mainly related to the use of this peyote cactus. And that becomes mescaline later on. We see that in 1936, this substance has raised a lot of interest, and there has been a PhD actually on peyote and the use of peyote in certain medications to stimulate. And this is sold in many different medications up until the 30s. So these are drugs that are aimed at producing experimental psychosis. We may administer this to people who are suffering from diseases, and we're going to observe if there are any kind of crazy symptoms. There's actually a conference of a philosopher that talks about the mechanism of this substance. Everything has evolved a lot from the moment in which LSD is growing in the international community. And I'm talking about the international community because LSD was very much used in the 50s, in the 60s, in Japan, in Egypt, in Argentina. So LSD is a substance that has lots of indications. Also in the medical world, there are many experiences on LSD about the perception of space, of time, of creativity. And here we have mescaline, which has been discovered by Maria Sabina, which is a Mazatec shaman. And for the first time, she provides information on this substance to Western people. And actually, there's a lot of knowledge gathered by the ancestors of this woman. And during the colonization, all this knowledge is kept. And Maria Zelina in the 50s, well, she conveys all this knowledge. She went to Mexico to recover some of these mushrooms. And Hoffman, a Swiss person, discovered this thanks to her. And the first thesis is by Anne-Marie Quetin in France. And then there are researchers in the 50s that are inventing with LSD and with other psychedelic substances a new way to perform psychotherapy. Before, there were shock therapies with LSD, but thanks to this specialist, there's the use of LSD in accordance to the psychic and physical state of the patient and the use of LSD is there to accompany all these people. There are psychedelic therapies with the administration of a strong dose 1 to 3 times in order to have a transformative experience. And then there's the psycholytic therapy with lower doses with 30 sessions, and this is rather based in psychotherapy. So there's lots of people and, well, women who participate in this research, and this is quite exceptional at the time. So the method setting is not very well followed because, well, there have been lots of deaths in psychiatric hospitals in France during that time. There was no budget, and actually, in those conditions, well, patients could not be there, and you couldn't have doctors accompanying the patients. There have also been lots of tensions between doctors and therapists. Doctors recommend to have to follow the patients very closely. And actually, male therapists have trouble following and staying close to the patients because they think that this is the role of the nurse who has to be, handing her hand to the patient. And Then there are two events in the 60s that make psychedelic substances lose their credibility. First of all, there's the randomized trials against placebo. I mean, all this works very well with current drugs, but it does not work well with psychedelic substances because you know since the very beginning who's on a psychedelic drug versus who isn't. So that's why they don't work so well. So the problem is, again, the counterculture. We said that there were medical doctors and psychiatrists and people in the world of psychedelic substances who are going to have links with Black Panthers, with the Black community, and there's a lot of conservatism in the US, and there's also this kind of panic, of moral panic in France. Dozens of articles that are published in France about LSD, mentioning that this is one of the most threatening substances, one of the most dangerous substances. So France is the first country to classify psychedelic drugs as toxic drugs, and actually there's then the interruption of research on those drugs. I mean, there are so many administrative burdens if you want to keep researching on psychedelic drugs at that time that everybody stops doing so. I mean, there's no financing, there's no funding, there's no support if you want to do research on psychedelic drugs. In spite of all this, research was pursued. There were some therapists who continued practicing, and they were pursuing this in Switzerland, for example. Then there were other therapists who would use psychedelic drugs to be in the same state and observe that. And then there were many other researchers who were observing the weird experiences of users. And then finally, we come to the years 2000 when we go through the psychedelic renaissance, actually, with three main factors. In the 19th, we have the decade of the brain. There's a lot of imaging as well, and since LSD is not too toxic, you can use it and see what's happening in the brain. And then we see that there's this therapy blockage. There are certain people who do not respond to the proposed therapies, so you need to do something about that. And then there's this distance by experts in the way they refer to this kind of psychedelic substances. So there are all these elements that have allowed for this renaissance of psychedelic substances to happen. And you can see here the main indications of psychedelic substances like depression, also addiction, and psilocybin and MDMA and LSD are the most studied. And actually, psilocybin is quite useful for therapists. It has some virtues compared to other drugs. And, well, psilocybin as well, many people don't know much about it, so it doesn't say much, where LSD is full of connotations. So here you have all these images that appear in documentaries. However, the reality is that in countries where these kind of substances are legalized, this is the situation. This is a private clinic, but the use is very limited, and there can be problems with this kind of treatment. And there's also a very intense mediatization. There's this article by Stéphanie Chaillet in Le Monde, in the main press, actually. There are lots of articles on psychedelic substances, and even Vogue, the magazine that tells us about some addresses where you can have psychedelic drugs. And sometimes there are underground therapists who are announced as well, and people who just want to make money, basically. Well, and I'm going to leave it here. There is a lot to do. There's a lot of hope around the use of psychedelic substances, but there are lots of questions that remain. How to train therapists? Because sometimes that's it. There's a lack of training in English, in French. And also, well, there's quite a poor background because in certain hospitals there's no money, no budget to promote all of this. So these are the kind of issues that come around the use of psychedelic drugs for medical use. Thank you very much. Well, in less than 15 minutes, you have just covered the entire history of the use of psychedelic drugs. And actually, well, we see that, you know, in past times, it was related to diabolic practices, and then there was this change of perspective. Now we're talking about this communication with cosmos, with this psychic adventure that is related to pleasure, and there's also the use of ayahuasca in the Netherlands, in Portugal. Well, I don't know. We have now invited Professor BOCKAERT to take the floor, because now we just want to understand a little bit better how these molecules work. So we are looking forward to hearing you. Thank you very much for inviting me. It is a pleasure to be here. I am not a medical doctor. However, I'm very much interested in substances and in brain and neurotransmitters. And I have worked on psychedelic substances and the mechanisms of the brain. When we talk about psychedelic substances, I mean real psychedelic substances, I mean the ones that were mentioned, mescaline, psilocybin, LSD. We need to talk about serotonin first and foremost. We see here that serotonin is placed at the very core. It has lots of effects on appetite, sexuality, the mood, empathy, sleep, lots of things. Sorry, we have just lost the sound. Now it's back. So, this is a product that will be released in the synapses, and then it will act on a receptor that will recognize it, and a network will be made. So you can see serotonin, that is a neurotransmitter that really innervates the entire brain. I mean, everybody, it's very developed. It's even in the spinal cord, you can find serotonin for the action against pain. So you have the synapses. This is what you can see at the bottom left-hand side, is these little balls. These are synapses. And then classical antidepressants like Prozac and paroxetine allow serotonin to concentrate. So serotonin, we have lost the sound again. I am so sorry about that. So why is serotonin important? It's important because of its actions. So if I'm not a chemist, but you can see here the serotonin chain. So you have a nucleus, and then you have the NH and NH2, and then psilocybin. Well, you don't need to be chemical expert to see that these molecules are very much alike, actually, and they will be recognized by the same receptor. I mean, the receptor that recognizes serotonin will also recognize psilocybin. And we have talked about this. It's found in magic mushrooms. And when we see LSD, sorry, there are these sound cuts. I'm terribly sorry about this. I don't know what kind of problem there is, but we can see that, well, when we see LSD, which is probably the best known molecules. So you see in the left serotonin, in the right LSD. You can see at the bottom of the molecule of LSD, we have this nucleus and then the chain that is represented by NH. So without being an expert, you can understand that LSD and serotonin will also act upon the same receptors, the same targets. All right? So when we talk about these receptors, we talk about serotonin receptors. Well, serotonin receptors are RCPG receptors. These receptors are in the membrane, and these are extraordinary receptors. I've been working on them my entire life, and they're able to recognize photons. So actually, if you're able to see, it is because you have receptors that recognize photons in your retina. And they can recognize as well lots of other molecules like hormones and other neurotransmitters. So these RCPG receptors are a family of receptors. There are 900 of them in the body, and they're very important, and they activate proteins. So you can see below those orange and green receptors, you can see the G protein. There are lots of G proteins, but we're going to focus on the receptors which you can find at the left-hand side of the screen, the pink and the blue, which are the coupled receptors to G protein. And amongst those, you can find 14 serotonin receptors. So there are lots of them. But there is one of them which is very important for psychedelic substances, which is the 5-HT2A receptor. This 5-HT2A receptor is the target for serotonin, as the others, but it's also the target of serotonergic classical psychedelic substances as LSD, psilocybin, and mescaline. Sorry, because I cannot find my slide, and there's a picture that has disappeared. But, well, never mind. We have here this 5-HT2A receptor. So how do I know that this is the receptor that is activated when you take psilocybin, for example? Well, you know that this is the one that is activated because it synthesizes a molecule that will be fixed on the receptor but will not activate it. It will be an antagonist of the receptor. The classical antagonist is ketanserin. So if a patient is taking a psychedelic substance, but at the same time you give him the ketanserin, the patient will not have the psychedelic effect. So we know that this is the entrance gate of this receptor to the brain. We also know that there are certain transgenic mice that do not have this receptor. They do not have the 5-HT2A receptor, and when they're provided with psychedelic drugs, there is no effect. Well, I know it's not very easy to see the psychedelic effect in a mouse, but the mouse who's under psychedelic drugs will nod his head all the time, will move his head all the time. And when there's this receptor, the mouse doesn't move her head anymore. So when we talk about hallucinogenic effects, it's not really that. It's rather a deformation of reality. I have to mention that this is normally a short effect. It's just a few hours. However, these products, these psychedelic substances, have effects, and they're interesting because they have antidepressant effects that are fast, but that are also sustained in time. And if you want to have a sustained effect in time in your brain, you need to have something else than just the activation of the receptor, because the activation of the receptor will only last for a few hours. So something is happening that modifies the structure of the brain so that this effect is long-lasting. And this is what we call neuroplasticity. The brain will be modified. It will have another configuration thanks to neuroplasticity. There are certain pictures that have disappeared from the slide. But how can we see this neuroplasticity? Well, in the left-hand side, there should be a picture of a mouse with a microscope that will zoom on the neurons. And this is a neuron that we can see in orange, and all the little balls, the little dots that you see there are synapses. And after an injection of psilocybin, there are more of these little dots. You can see them here. So there are more and more dots after the injection. There are more and more synapses. So you can see that there's a proliferation of synapses for 35, even 60 days. So there's this neuroplasticity that is really long-lasting. We're going to modify the brain for a long time. Actually, the brain is something that you modify every single day when you learn something or when you listen to something. You just modify your brain. So there's this plasticity of the brain that is happening here, and it's happening for a long time. So here we have this receptor, 5-HT2A, and we have these synapses that are produced, and we can see here what's going on in the brain. There's the connectum here in the top left-hand side, the connectum, which means lots of connections, and this takes a great part of our brain. And there are networks that are more specialized than others in certain actions. For example, if you are doing something, you have the executive brain that is taking place. If you think about your personality, if you think about your past, if you think about your future, or whenever you are mentally considering something or having a certain emotion, or you're just focusing on yourself, then there is another network that is taking place, which is the default mode, which is very active when you're doing nothing. I mean, when you're not doing anything in particular, when you're not executing anything, you are in the default mode. You're just ruminating. So the default mode, now this is a little bit more complicated. I'm talking about the bottom right picture. When we see what's happening in the brain, you see that it is the default mode which is more affected by psychedelic substances. There are lots of networks that will be affected by the use of psychedelic substances, but especially the default mode. And when we think about this mystical effect of psychedelic substances, well, we see that this is very much related to what I was saying. So there's a change in the number of synapses, but there's also modification of all these networks that structure our brain, especially the default mode network. And the default mode network is very active in depression, in addiction. And when you use psychedelic drugs, the activity of that default mode is reduced. And the depressed person is usually self-centered and ruminating. She's not open, that person is not open to the world. And with psychedelic substances, there is this effect of opening that person to something else other than the person, him or herself. So that's why the use of psychedelic substances is related to antidepressant effects. So there's a debate going on about whether Well, we know that psychedelic activate the receptor 5-HC2A. This is the beginning of everything. Now, the issue is to know whether psychedelic effects and hallucinogenic effects are necessary for the antidepressant effect. Because as I said before, if you want to have a therapeutic effect, you need a psychologist, you need a certain context, you need a certain space and a certain organization to provide those psychedelic drugs. And, well, this is quite expensive. This is quite difficult to spread, all right? So the issue is, can we find the substances to activate the receptor 5-HT2A that will not have the psychedelic effect, but will preserve the antidepressant effect? We said that hallucinogenic drugs like LSD or psilocybin will activate the receptor. They will activate the G proteins. And you're going to activate all those proteins and many other things that I have no time to say. But there's lots of things that will happen in your neurons. However, you can also find non-hallucinogenic drugs that will activate the same receptor. For example, lyseride. Lyseride is a product that is used by clinicians for Parkinson's disease, but there are many other labs that synthesize products like zalzupindol that will activate the same receptor, but without the psychedelic effect. And there are these antidepressant effects. And as I said, this has been studied in mice for the moment. And we see that zalzupindol is in a clinical phase of the trial. So we do hope that there will be substances that will have the activation of the receptor, the antidepressant effect, but without the hallucinogenic effect. So, of course, now there's the debate about all of this. So can we have an antidepressant effect without having the psychedelic effect? So this is the debate going on right now, and there's some who think it's not possible, and others think that you need this spectacular psychedelic effect if you want the antidepressant effect, and other people rather think that it's not necessary. And I think that it may be a mixture of both positions. Thank you very much.
Okay, thank you very much, Professor BOCKAERT, for this dialogue between traditional knowledge and these ancient cultures with all these plants, ayahuasca, with magic and sometimes medical effects, and Western science that wants to know how it works, but they are molecular. What is interesting is to see the stimulation of the receptors, the 5-HT2A receptors, and these principles that we could find in cactus or mushrooms will have a psychedelic effect. Another important element, it was very well said by, the sound is cut. I don't know what happens. Yeah, sorry. Okay. With these drugs, when they work, the effects will be fast. But what is more surprising is will they be long-lasting? Because sometimes people, may suffer from relapses. And on the contrary, unlike this situation, we could have long-lasting effects. And we are going to see in practice, is it a mystic experience or is it the antidepressant effect of the molecular? We count on Daniele ZULLINO to clear it because he has a practical experience in Europe. He is one of the most experienced in physician in clinics. For those of you who don't know him yet, sorry, yeah, didn't get this these final words of the moderator. Well, the regulation of cannabis in Switzerland. Okay, what we are interested in tonight is one of the main specialists in the world in Geneva. Do you have the same rooms as those who were presented to us with a nurse rubbing your hand? Are you the psychiatrist 24/24? No, no. In the evening, I come home. I come back home. Well, thanks for giving me the opportunity of telling you about this. Just to introduce a bit the fact that I am from Basel. I grew up in Basel and I studied in Basel. I could knew Albert Hoffmann. This is a starting point. I not only knew him, there are many mushrooms that grow around Basel. It doesn't mean that I ate all these mushrooms, just to tell you that it exists. Let me remind you that everything started in Basel, in Switzerland, and Albert Hoffmann not only discovered the LSD, he is the first one to isolate psilocybin. So from Basel, from the pharmaceutical industry, was the development of this research axis, which stopped suddenly at the end of the 60s, beginning of the 70s, but not in Switzerland. What we do not know is that during the 80s, Franz Vollweider started again to study on this. It was possible not only research on this healthy subject. From the 80s, there was the possibility for five physicians to treat in Switzerland, to treat in a limited way with DMA, so not with classical psychedelic, but afterwards with psilocybin. It has always been, we are far from America, we are not in Europe. Well, some things are possible sometimes in Switzerland. Albert Hoffmann died at the age of 100 years. We organized a symposium in his honor, and some colleagues, well, thought that the things should be launched again. They wrote a letter to a minister of health minister to ask him whether it would be possible to use these substances. They got yes as an answer. A first survey was done by Peter Gasser, a physician with a private office, the new pioneer in Switzerland. And in the year 2014, the Federal Office of Health decided to allow a prescription, a limited prescription with exceptional authorizations. It was a compensatory usage. There were first experiences, and we started in 2020 on that. We were the first institution, the first hospital to be there. Well, as for a little history, I had told about this to the rector of the university. They knew that we were used to work with narcotics, and we did it on a Sunday, not to make too much noise. With two patients, we had the authorizations. It worked well, but the nurses were very enthusiastic, and we started to do it. And last week, we reached 530 patients. Last year, we did almost 200. This year, we have reached this figure, so it is an exponential growth. Last year, 600 treated patients by us, with 60 physicians and institutions that participated. Indications are very varied. Compassionate use, if we argue it well, we can go beyond what the controlled surveys present to us. There are many colleagues, somaticians also are interested in this. Research, well, there is much research in pharmacology. Matthias Listi in Basel, of course, who set this up with several substances. The most interesting thing, which doesn't exist away, he made many research on the active substance of ayahuasca, with the particularity that the action is very short. So after bolus injection in 5 minutes, and after 5 minutes, the individual reappears from his trip, and you can have a talk with him. But we can talk after my presentation on Thursday. There will be slides, and we will have to come back on this to review all that. This opens nice horizons. Do we really need to have the psychedelic effect to be efficient? This is another question. Do we really need to have all these trip hours? Do we need to have this psilocybin 8 to 10 hours in LSD? We will know it when we will have the possibility of doing shorter trips with interventions yet during the same day. Presently, the first interventions come the day after, and we will have something mixed. So far, we've been doing psychedelic sessions, so we do have states, deep mystic states that allow very little interaction with the patient. Now we will have the possibility to interact directly. It is the psycholytic model which had been developed in Europe in the 60s based on the psychoanalytic model. What we are interested in, since we have the possibility to use these substances in real-world conditions, in vivo, without having to worry too much about too many factors, are the aspects of set and setting in preparation, and how, well, it is research and action, how to prepare the patient, which are the aspects, how to prepare these therapeutical objectives. We bet a lot on this to remind you that as for psychiatric indications, these indications are last resource embedded within a psychotherapy project. So there is first psychotherapy, and there must be another one at the end. The duration can be discussed. We can discuss it with the Federal Office of Health. How do we prepare best to first to have more effects? Because the more the effect is deep, the more the effects will be therapeutical. So we want to show a correlation. This doesn't mean that there's not necessarily a correlation effect, but we need to induce this psychedelic state and the peak effect. The second part concerns the setting, the big question of environment. We do not have mandalas, we do not have all colored cushions, well, pillows. Well, music, yes, we do have music. I'll come to this. Asian and African mask are on my desk, but not in here. Music might be helpful. Well, I can't tell you about the data, but we start now our researches. we need some music, new age music, not vocal, not known by the patient. We've just done the experience that almost all music's work. We know it from the non-medical experiences, whether it is the Goldberg variations or AC/DC, everything can work, but it depends on the stage of the patient. So we started to prepare together this music list with the patients. We had the idea of making it work during the session, whether it was memories. So we could choose some music fragments or pieces that would evoke some memories of the patient. What we realized is that music often or always work, but there are moments in which the patients don't want any more, who they prefer without music. We are always here. We do not have sitter accompaniments. We have one person on one or two patients. We remind them that they bring a mask, they look inside, so decoration should not intervene too much. They have the possibility to bring some objects, symbolic or comfort objects, but the patient will look inside herself. This is their space. A person whether this is a nurse or a physician, they are all trained to intervene, to do talk down. There are hard moments. There's always a doctor for 30 seconds away from the room. There's also a doctor which is present on the same floor. We just had to stop 2 sessions out of 530 patients. One was due to an epileptic seizure. Well, with little probability at that time it was LSD, and another case in which the challenging effects were too anxiogenic, and we could stop it with some benzodiazepine. Well, this might be an important aspect also. We are discussing a lot in Switzerland about training models. We propose them since, sorry, the sound is cut. We apologize for this. Okay. In a pre-grade course with university students, we were the first university to propose it in Switzerland. What else? Well, I think that to contribute to the debate, we can see it in Switzerland as we can see it in France or other countries. We mix 2 types of Renaissance to which we assist nowadays. We think that the mixes of the 60s could be problematic. There is a renaissance of the therapeutical interest of these substances. So scientific development of mode and therapeutical products. Sorry, another sound interruption. This is a pity, but we can do anything, sorry. Of the strictly therapeutical use, the base of the 2 debates is not the same. It is mixed, and this is dangerous. I am talking in France, in the country of baclofen. What was the name of the Marseillan substance? Well, okay. It is not by popular vote that we should decide whether a substance is efficient or not, therapeutically at least. On one hand, we have the therapeutical development, which must be based on a scientific debate, and on the other hand, the access to this type of substances, to the public, to people, which is a civic right and not directly scientific right or situation. Yeah. So in Switzerland, there is much pressure of the public opinion to give access to this substance to huge amount of people with therapeutical objectives without knowing the scientific data. Switzerland opened the doors for the use, the therapeutical use, compassionate use, and it will not be marketed until we get the good data. So a Swiss model to copy, but with prudence. Thank you, Daniele, for this pragmatic approach as well as scientific approach. Globally, the risk-benefit is favorable with very little major incidents for the involved people. Accompaniment conditions can be managed without asking for redeploying ambulatory. Yeah, marvelous.
It's an outpatient setting. So, well, this is quite encouraging, outpatient setting. And you said as well that there's also the risk of having this kind of expectation effect. And I remember in the works of Ross and Bossis that they said that this was indicated for resistant depression. For example, people who were affected by cancer and they were suffering from a huge depression because they were just facing death. But when they were offered psilocybin, they would refuse to receive that because, well, they didn't want it. And maybe these people had the experience of psilocybin when they were younger. So, well, we see that there's this expectation effect, and this is very important. So for you in Switzerland, and I will also give the floor to Eric Strain to tell us about the US situation. Is there any kind of filtering of patients depending on the potential previous experience that they may have had with psychedelic drugs? Yes, you're right. There was a lot of demand, and we had a waiting list at a certain point of 800 people. There was also a lot of demand from France, but you need to be a resident in Switzerland in order to go through this treatment. So we could not accept that demand from France. And now, you know, normally, well, from all the people that request that, we retain 1/3 of them. We screen them, we retain 1/3 of them. And some of them have been enthusiastic, and at a certain moment we may have not been cautious enough, and we may have had some poor experiences with certain patients who wouldn't stand the session. So there have been some counterindications, and this is shared by all of our colleagues in Switzerland. There can be, some of those experiences. And then there are some patients who just want a certain date and they want some kind of accompaniment. Now we are becoming more and more strict when it comes to really screening. We take like 1/3 of those who are just requesting. There are certain patients who just want to go through it. Thank you very much for being so accurate. We're thinking about many possible questions, but we were asking some reply to the previous presentation. So, Eric Strain, if you're listening to the translation, I guess that you're listening to that, could you please let us know the situation in the US? Because it's true that there has been some kind of a delay between the protocols from hospitals and certain practices that have been put in place to respond to some public interest. So if you could just let us know about what's going on in the US. Thank you very much.
Thank you. And thank you for letting me take the earphones off. So I think it's been a very, first of all, thanks everybody for your talks, and I've followed 75% of them, which is good for me. I think the expectancy effects in the United States, which I think is what you were asking about, is a really great question. Lykos, which was the company that was developing MDMA, ecstasy for PTSD, they got criticized by the FDA, the Food and Drug Administration in the USA, for not controlling for expectancy effects in their what they thought would be their pivotal clinical trial for getting MDMA approved for PTSD. So that was, I think, a real wake-up call in the United States for controlling expectancy effects. And there's been, am I talking too quickly, by the way, for the translators? We okay? Are they translating okay? Who knows? Okay. I can talk faster. So I think that's really been a wake-up call in the States to the controlled trials and trying to make sure that they do control for expectancy effects. I think the second thing, though, that's come up is what are the control conditions to be used, for example, for treatment-resistant depression or depression, which is probably the next indication that's going to go for psilocybin, either by Usona or Compass are the two main companies working on that. And I'll talk about that Thursday in the session that we do, and about what kind of effects are being seen. But, are these control conditions adequate control conditions? And there's been a lot of them that have been trying to do something to produce a robust psychological, a robust effect to mask whether or not you really got psilocybin. Did that answer your question? Yeah. Okay. I can talk more, but thank you.
Merci beaucoup, oui, puisqu'on savait effectivement que la FDA, ça a été
Thank you very much, because we did know that the Food and Drug Administration was behind it, and they had interrupted the phase 3 of MDMA for PTSD. And if the researchers may have not taken into account the expectation effect enough, and this is something to consider. There are many other elements, of course, and I think that Zoe was mentioning this control, or this kind of control. I mean, people know that they're part of the control group versus the other group. I mean, it's quite obvious. And then Alexandre is going to tell us about his experience in the field as an actor and animator of the Psychedelic Society in France. They're very active, by the way. And maybe we will have some time for questions as well in the room. Yeah, thank you, Jean-Michel. Yeah, I just wanted to step aside a little bit. We can talk about all the things that are going to happen in the brain, the patients that we're going to follow. We have not talked about patients who go to see shamans. And I see that Daniele has distinguished different kinds of consumption. Now, in France, according to the latest study of the Health Barometer regarding addictive substances, there was a figure there's 8% of adults in France who have used psilocybin and 4% who have used LSD. So maybe there's some kind of recruitment bias, I mean, for the people who are following us online, but, you know, some of us have already used these substances. Amongst these people, you were referring to my hat as a risk harm reduction actor. And I know that there's here all the people from BZA, there are people from MSF, and we have all met in the past in rave parties to accompany people who had had some difficult encounters with psychedelic substances. We have inspired many community actions as well. And actually, as Jean-Pierre was doing before, I would like to now pay tribute to Dédé Benezek, who passed in the last years, and actually he was passionate about accompanying people who have used a psychedelic, and he trained us on that matter as well. And I would like to pay tribute as well to Fatima Shiman, who was a psychologist, and she's not amongst us anymore. And well, these people were very important in all of our endeavors to help people who have been using these substances. All right, so now I'm going to tell you what we're doing at the Psychedelic City in France, which is an association that is acting on the use of psychedelic substances. Zoe is another founding member of the association, and we are very much interested in harm reduction. There's this manual that we have published, and it's there in the at the entrance. You can have a look at it. And, well, we tackled the issue of how to support people who are going through all these experiences, because it's not easy for the use of psychedelic substances, as it has been mentioned. There's this screening, and there's this lack of suitable spaces. But I have to say that when it comes to the use of these substances, there are very little undesirable effects. There's 20% of psychedelic consumers who describe having suffered from non-desirable effects, and just 1% of them who say that it lasts beyond the crisis. And there are some focus groups for these matters, for people who want to share this kind of experiences. And this is community health. And this is something that we do. We work in collaboration with different researchers in France on the possibility for patients to join this kind of groups. We also try to help people who have undergone depersonalization phenomena. And it's true that there's a lack of space, of suitable spaces to support this kind of people. So I hope that we can develop further partnerships for that purpose.
Merci,
Thank you.
Alexandre.
Thank you, Alexandre. I think it's very positive to have a representative of harm reduction here. And it's very positive that you're saying that there can be non-desirable effects in the use of these substances, even in hospital settings. And actually, some counterindications, you know, for people from my generation, there were some people who would have received these drugs, these users, and it's true that there are certain harm reduction actions to be made at a community level. Okay, well, now we're going to give the floor to the audience. Jean-Pierre is telling me that we may have a little bit more time. I would like to come back to what Zoe DUBUS was saying regarding this key moment. You were talking about that science was refusing the use of psychedelic substances. There was some kind of moral panicking. And yeah, I think that there's moral panicking regarding the use of any kind of drug. There's also the Bandol issue, the case of this young woman who died after an overdose of heroin. And then there's all this media effect that has lasted for months. Sorry, we're losing the sound again. And then there's the Act of 1970, the piece of legislation. And it's true that France used to provide 70% of heroin. But this Act of 1970 is also the result of moral panicking. And this is also something that was causing havoc in science. I mean, how are you going to research on illegal products? And it's the same for cannabis. You know, there has been so much debate about the research on cannabinoid substances, but these substances were forbidden. So, of course, there's the burden of prohibition, which has played a major role, making science turn a blind eye on the substances. Thank you very much. I'd like to know your opinion. Yes, you're true, you're right. You're talking about the Act of 1970 related to the reaction to this moral panicking after the consumption of cannabis and LSD. There are certain historical studies that tell us that there was not so much consumption. However, well, for the media, it was really very useful to kind of panic about the use of these drugs. You also mentioned the crisis of via heroin during the 70s and 80s. There was this French connection, but the French connection would hold the market and would sell almost pure heroin, stable quality heroin, and then there's the dismantlement of that, and there are little dealers who are cutting heroin, and it is then when the first deaths appear. So prohibition is a moment that leads to the interruption of many studies on these substances. And also there's this administrative burden as well. And this leads to a higher risk for users. And this prohibition existed as well in 1916. There's the first piece of legislation in 1916, and there's this morphine phobia at the time, where the use of morphine is forbidden in hospitals. So prohibition has huge effects on the users, but also in the development of science. Are there any other questions? I would like to say something, actually, about the fact that, yes, in the 70s there was a total rejection of the use of psychoactive substances that could lead to addiction. But I have been part of the Commission of Psychotropical Substances, and we've been in charge of classifying substances. But it's true that we used to say that for hallucinogenic, there was direct prohibition. And opioids, however, were used in medicine, and there were stimulants as well, amphetamines and so on. Even though, certain people would think that certain substances were useful for medical purposes and others weren't. I mean, there was a huge stigmatization on the use of hallucinogenic drugs for medical use. And, well, even though in Switzerland we discovered the beneficial effects in the 70s of the use of these substances. Any other remarks? Any other questions? Any reactions? I think there's a hand over there. C'est une question.
You know, in the United States, the only indication for the treatment of PTSD by any kind of psychoactive drugs is cannabis. However, based on the studies conducted mainly, I'm talking slowly for the translation, on our veterans, it has been found that expectancy actually was the most important aspect that contributed to positive outcomes, meaning that veterans, meaning soldiers, you know, that are in treatment, that have were not believing that cannabis would be useful, have not improved as compared to those who thought that cannabis is useful. Now, getting back to your short kind of comment, and I'd like to hear more about it hopefully today, is yes, I agree with you that lack of studying expectancy in outcome studies is problematic, particularly about what we know about cannabis. What is associated with it, as you mentioned, is consider the alternatives, meaning if you want, or somebody wants to treat resistant depression and put it in the algorithm, put the psilocybin, for example, the question is, what are the other alternatives? Would you do ketamine first? Would you do transcranial stimulation first? Where, according to your expert, because you are the expert in the US, should psychedelics be in the algorithm? Thank you.
So let me first of all say, I am really bad at predicting the future. I would be very rich if I was good at predicting the future, because I would own lots of stock. So I'm not sure what will happen with it, but I do think that we need data to decide what to do with these medications. And I think a question that we're struggling with is, do we hold these medications to the same standards that we use for other medications, for other conditions? Because unlike most psychotropics, which require time to show an effect, these medications appear to produce robust effects quickly. And so they're very intriguing that way and very sexy, if you would. So I think that there's probably a signal there for something like psilocybin for treatment-resistant depression. And I think that it probably should be, if you go with the treatment-resistant depression, that would be the failure of 2 adequate trials of an antidepressant. So I think that that's probably a very good indication there. I would suspect that probably we would see it as a useful first or second line treatment for depression, probably second line, even for not treatment resistant depression. The problem with this is going to be, and I've got a lot of thoughts, but the problem with this is going to be cost. I don't see, it's expensive to do a psilocybin session, at least in the model that Hopkins has used, that Roland Griffiths developed 20 years ago with, cancer, depression, and anxiety, the first paper he did. It takes 2 therapists, it takes pre-session, session, post-session, sessions. It's an expensive undertaking. Even you can look at ways to do that. Maybe one person monitoring multiple sessions, so on. It's still expensive. And if the effects are sustained, why would a company make and market a drug that you only need to use once? The great thing with Prozac, fluoxetine, is you keep writing prescriptions month after month after month, and the companies make money. With a single dose of psilocybin, if it treats your depression, and Alan Davis, who is a postdoc at our program, just published a paper showing 5-year outcome measures for 24 people treated for depression with psilocybin, and they're still better. Now, most of them got other sorts of treatment, but most of them are still better, the overwhelming majority. The financial model falls apart. So I think it probably could be a second-line treatment after SSRIs or something. I think it will probably work. I think the real crux of the question is going to be, how do you make it financially work for companies to produce these drugs? Did that make sense? Yeah, but my time's up.
Merci beaucoup. Oui, c'est une des questions qui se pose d'un point de vue.
Yes, indeed. You're right, and this is one of the issues from a pragmatical point of view, because the treatment is very efficacious, it is very fast, but it's also very sustainable. I mean, you may have 1, 2, 3 doses, and the effect will be sustained. So what is the interest for pharmaceutical companies that would prefer traditional medications like Prozac that you can keep on prescribing to make profit? And then another issue that you reminded us of, Professor Strain, is that, this second-line treatment possibly for treatment-resistant depression, cancer, and so on. And I would also like to join what the gentleman was saying regarding this expectation effect for PTSD and the use of that drug for veterans. And we see that there's this expectation effect that is huge. And so, of course, that there's this need of further studies and well-controlled studies on the use of this drug. Are there any other questions? Any further questions in the room? I think there's one there. I think that there's a microphone coming for you. Miguel Velasquez, Sud. So I'd like to know about the limitations of these treatments, because, well, these treatments are scarce, there's lots of expectations, as it was said, and now for problems like addictions to cocaine or depression at the end of life, cancer. It's true that it may be very interesting. However, to treat opiate addiction, I am a little bit skeptical about any positive outcome, because there's the problem of craving, physical craving. This is a major problem that goes beyond the psychological problem itself. I mean, there's also the psychological craving. Yes, that may take place, but there's not only craving. I would like to know what your opinion is. Yeah. I'm going to give the floor to Daniele.
Well, it depends on therapeutical objectives. If we have non-consuming abstinence, well, that time it will not work. But we have treated a series of patients for addictions to opioids, and there were patients who were prescribed medical heroin. The morning they would take their heroin, and afterwards they would receive another substance. They do not stop using these substances. Sorry for the sound cut. Yeah, they can play another role in their lives. This launches again another psychotherapy, whether they are drugs or opium derivated, we open windows for reflection, room for thought, regardless of the substance which is used. We have opium with crack and users and who didn't use crack anymore. So I don't think that the substance is the criteria. It is more the work on objectives which are not abstinence.
Thank you. Let me say, oops. Dependence, which is a pretty hard thing to break. And they had failed 2 prior treatment episodes, adequate treatment episodes. And he did a psilocybin session with them. And he got sustained abstinence from smoking for over, I think it was 60 or 70% for over 6 months. And I think they did a follow-up a year or 2 later, and a majority were still abstinent. And that's biochemically verified abstinence from nicotine dependence. Now, keep in mind, in the States, the best medication for treating nicotine dependence is Chantix, varenicline, okay, which is about 20% is what the studies show of sustained abstinence. So he was getting over 60%. They've done a follow-up study, Matt did, with Albert Garcia. It's still under review, a controlled study now with a control condition in it, and they're still showing something on the order of 50% abstinence, biochemically verified. I really like those studies because it's a substance use disorder that's got biochemical verification of abstinence. And I'm a psychiatrist, I treat people with depression, but at the end of the day, depression is a self-reported measure of outcome. But nicotine dependence, it's a biochemical verification. So that's really interesting data, I think, on the possible efficacy of these medications for the treatment of a substance use disorder. Thank you.
Alexandre?
Oh, you.
Well, ok, peut-être juste modestement pour compléter.
Yes, maybe humbly to complete on substances, very addictive substances. I think that alcohol is the first ranking or second ranking the day after tomorrow or tomorrow. I don't know. Amandine, who will tell us the first French survey about psilocybin in alcohol-associated intakes. Well, there was an abstinence, there was the first craving, and, well, a very small dose of psilocybin, almost a placebo, and potentially a modification of the relationship of alcohol consumption, which is very interesting. I think that potentially psychedelic, that is what could show. One researcher had shown these results on tobacco 2 years ago. One particularity of the psychedelic is the relationship and retaking the possibility of managing use. I think it is a more than interesting challenge. Yes, thanks for having mentioned Amandine work. Yes, which makes the joyfulness of our colleagues from Montpellier. Are there other questions, other comments? Yeah, in the middle of the room. Hello, good evening. Just if I may, some remark about the legal status of the product. That would be an offense to the freedom of use, which I am relatively, I agree. But I was contradicting myself. The e-cigarette is quite interesting since it is not illegal, but we have then a product which is condemned not on a legal basis, even though it is regulated, but morally is bad, wrongly perceived. It has been difficult to do some research. The only countries who succeeded in researching sufficiently enough interesting data are the States and Great Britain, which has legalized e-cigarettes. Whilst the legal status is not forbidden in France, it was difficult to undertake consistent researches in France, so to have sufficiently enough robust data to the point once a product classified, once it is legalized, the whole problem is not solved. The discussion continues just after its regulation. And the question that is being raised is, what are we doing with this story of the pleasure which is behind, the difficulty to frame the pleasure that the person will take to get out of combustion, not nicotine. So I would like to share these thoughts with you because it has to do with harm reduction and how can we have access to products in a society with the expectability or expectancy about products, and how can we manage and on behalf of what? How are we doing this? We get out of scientific debate to go to land more on a cultural debate with our representations about access to pleasure and how it has to be managed in a certain way. Thank you. Are there some thoughts, reactions, comments? Mr. Saint-Lazare? Well, it makes me think of one of the problems with e-cigarettes is that people inhale nicotine and it has an addictive representation of drug, and this pollutes this intervention, which is more an intervention about risk than of care. Jean-Pierre mentioned the debates on methadone and the struggle about these many players thought in terms of care. It is a work about representations which is relatively classic. The struggle for harm reduction is not won in our country nor in other countries probably. Jean-Pierre? Thank you all for these fascinating remarks and contributions. A question to Daniele ZULLINO, mostly, and also to you, Jean-Michel, who have followed the system of classification of substances at the FDA, the French FDA, Agence des Médicaments. I am so sorry for our country and admiring the pragmatism of Switzerland, because within this domain, as well as in others, they experiment with a much scientific rigor. These fields that could be less sensitive than heroin, but Switzerland knew how to to experiment the heroin programs. Simon and yourself know a lot about this. The same way, Rudrefu told us during the last THS how Genève and Lausanne were starting an experience not of legalization but regulation of cannabis. And she told us that all these experimentation capacities with molecules which are classified, which are prohibited by international classifications, how they could be in Switzerland because they considered that it was an experiment-like researches, which seems very pragmatic and smart to me, if provided that this is done with enough rigor. So it must be made thoroughly. And is there a sort of refrain, a legal refrain linked to the classification of certain substances in France which bother experimentation? And have you got ideas on how we could make this French approach progress so we would be next to Swiss? I will not answer for France. Well, just to link it with the last remarks, I think we can discuss on the good use of substances, whether it is possible to use them. The idea of pleasure is within the public debate, the public sphere, since we can theoretically, at least, we can have access to it. I think Switzerland is a good example, but that cannot be copied elsewhere. Switzerland is a federal state imposed by Napoleon. The cantons, the counties were imposed by Napoleon, and thanks for this, because it is very much useful. What is possible in Switzerland, and it is Ruth Dreyfus' invention. So experimental laws, we draft a law, we implement it, we passed it, and for a certain time, if it goes well, we draft a new law and we regulate. We've had already done this with the caisse maladie, with the insurances, and now we are doing the same for cannabis. The advantage is that each district can decide by itself. There are regions which are more progressive than others, more advanced. Genève, Bâle, Zurich, Lausanne, they are much more state-of-the-art than primitive canton, primitive districts. Primitive because they were the first ones, okay? And normally they are much more conservative and reluctant. Heroin is not prescribed everywhere. Some cantons can accept it once the others notice that it works, and then the others can follow. So there is the idea of the pilot experimental law for cannabis. It's on 10 years. We can do experiences. We can experiment on several regulation models. In Lausanne and Genève, both have a non-profit model. So it is with a strong presence of the state and prevention and therapy offices. Ruth Dreyfus is the president of the association in Genève, which is leading this project, of which I am the main investigator. There are other projects which are ready to see the light, to be put on the table according to several models, and remotely we could make some cantons choose between amongst some models. I think you could do this in France also. You imposed us the model, so you can impose it to you. What is extraordinary is that we are penalized in France. Alain Rousset, the president of Nouvelle-Aquitaine, said, I do like this kind of experiments. First, we had to set methadone. It was a true war at that time. But there is the problem of the supervised drug use rooms in Bern. Sorry, there is a sound interruption again. Sorry, we apologize for that. So, yes, but the centralization, the Jacobinism, French Jacobinism, everything is being decided in Paris. And I am astonished that Swiss federalism is a heritage of Napoleon, because in France there has been a huge centralization. Maybe we might accept the creation of new cantons, new districts. Well, Nouvelle-Aquitaine will reflect on this. If I can give you my advice, I agree regarding what you say vis-à-vis regulations of cannabis. It is easier to set a model such as this model. We could imagine that, well, it is a political problem that pays to many other arguments others than health arguments. On the practice, with more than 30 years of experience, I could say that things evolve favorably. At the beginning, it all relied on the Ministry of Health. When the ATHS was created, there was an absence, an agent with some experts. But at that time, well, I am not criticizing them. They are extremely competent. They could see the problems at the light of toxicity because they were just scientifics. And there were many representatives of public powers, Direction Générale de la Santé, representatives of the ministries, and decisions were made in a very critical way, and things started to change. I was the reporter of the RTU about Baxifren, so things were getting opened and experts were more diversified. We started having psychiatrists, representatives of the users, the Commission des stupéfiants, the Commission of toxic products. The blockage didn't came from the Agence de Médicaments. It used and regulated the use of psilocybin, the use of cannabis for people who wanted to quit smoking. Well, what will be blocking it is not at the level of the agency, the drug agency. It is more of a political matter now. And the technical advice of experts, I do think that things evolve favorably, but on the contrary, we have to say that there is very little follow-up. And the consumption, the drug use consumption rooms, well, will have a very little follow-up, but I would say that we are getting at the end of the experimentation of these rooms. Thank you. Sorry, sound interruption again.
Oui, alors, question peut-être, je vais essayer d'être
Well,
clair.
I will try to be as clear as possible. Before, you were talking of the receptors to have a psychedelic effect, or the fact of having molecules that stimulate these receptors to have effects, antidepressant effects, without having the entheogen psychedelic mystic side. I was wondering whether these are more commercial challenges or philosophical challenges or political ones, and were they also constraints? You were talking of constraints as for the means. I mean, time and people, employees dedicated to support, as well as venues, adapted venues to the psychedelic experience. So a drug that could have a short action could be taken in a much more easier way within the frame of health. I was wondering whether about the treatment, this entheogen and psychedelic side could have a beneficial effect on treatment or therapy during the accompaniment or the support. Is it purely a neuronal effect, or the fact of having this experience of modified conscience has an important way on the global treatment?
Vous y répondez aussi bien que moi. Donc, depuis longtemps, on a observé, moi-même travaillé.
For some time, we have seen that there's a number of products that act on the same receptor. Some of those products have psychedelic effect and others haven't, even though they have the same affinity and they act on the same receptor. So from a pharmacological point of view, this is quite a surprise, but it's also a big problem. There's a lot of data showing that psychedelic products will modify transduction, so the interneuron activation in a different way than non-psychedelic products. But the solution has not yet been found. So this is a pharmacological surprise that we want to explain. And that's why many people think, well, if these products act on the same receptor, could we not have the antidepressant effect in those non-psychedelic products? And that's why there are lots of labs around the world, especially Galenic labs, that are interested in researching on these products that have the antidepressant effect without the psychedelic effect. But of course, as I said before, all these studies have been carried out in mice. So in mice, it is really very clear. If you take this lizaride, which is used against Parkinson's disease, there are articles that show that this product may have, in certain cases, psychedelic effect, but many very minor psychedelic effects. So could this be used as an antidepressant? Well, you know, there are lots of, and here these products work, at least in mice. Now, will they work in human beings? Of course, I said there's a phase 2 under course right now. Maybe it will work, but it may work less well as those products that have a psychedelic effect. So will it have the same effect? You know, in mice, the studies were short. Maybe there's going to be an antidepressant effect, but just for a couple of weeks. I don't know. This is still under study. And these are just some pharmacological considerations and some fundamental considerations as well. Can we distinguish both effects, and can we use that for an antidepressant effect on human beings? You know, the question remains open. And then, of course, we may think that a product that acts upon the 5-HT2A receptor, that is an antidepressant and non-psychedelic, would be easier to use. It's going to be less complicated, that's for sure. Maybe it will be not so efficacious, who knows? The future may tell. Yeah, maybe I have a couple of things to add. We have talked about the pharmacological effect, but let's remind that psychotherapy is efficacious in cases where pharmacotherapy does not work. And there are certain studies that contain a psychotherapeutic component. It's psychotherapy. It's about, changing something in your expectations, in the mind of patients. So never forget there's also psychotherapy next to it. There's a study in Basel where these substances are applied under anesthesia. So this is an interesting way to see what is going on. I don't know if, there's propofol as well, which has effects, of course. But, and then there are those who think it would be a shame not to enjoy those effects. There's a pleasurable substance with all those dimensions, so why should we block this? So there are those who think that these effects should be preserved. So I will insist that certain people want to favor the psychedelic effect. I would like to react on what you were saying. I agree with what you said. It's very important to protect the psychedelic use. But maybe certain patients do not want to live this psychedelic experience. So having the possibility of resorting to a substance that may have the same antidepressant effects without the psychedelic effect, well, it will just enrich our therapeutic arsenal. So it may be interesting. Maybe it's not the right time to open this debate right now, but I think that you were opposing everything regarding pharmacological and as opposed to psychotherapy. And I don't think, I think this is an artificial distinction. I think we have to bear in mind that they're both come together, but it's two readings of the same thing, basically. This reminds me, as an intern, there was this professor of psychiatry, and at that time there was brain imagery that was a trend, and we could show the effect of psychotherapies, and we could see with psilocybin, we could see some mystical experiences that were described by certain people, or maybe the most intense effects, and we could see that on the brain images. So this reminds me your debate before. I think that one of the interesting elements around psychedelic drugs is that it allows us not to oppose psychotherapy to a pharmacological treatment, because they can go together. So there's the possibility to think about a synergy, about a synergetic effect, bearing in mind that what works better is what the patient believes in. Actually, it's what the patient wants. This is what will work better. He or she wants. We want to respond to the patient's expectations. And now to go back to those shamans, let's not forget that religion helps as well. Sorry, there's been a cut in the sound. And there's Professor Jacques Besson, who was actually considering this spirituality. And of course, this is something very difficult to develop in France. All these aspects are difficult to introduce in the country, let's say, this spirituality or appeasement in people. I don't know if there is still any question or remarks, or otherwise I'm going to look at Jean-Pierre. Maybe it's time to close. Well, thank you. Thank you very much to all the people here in the panel. Thank you. So, well, this is the kind of atmosphere we like. a warm atmosphere in ATHS. So, yeah, we could, I think that we could catch up. I hope that this was just a trial to be sure that tomorrow everything's working finely. Again, thank you very much for all your insights and for such a rich and passionate debate. I'm sure that there will be many other debates like this. Thank you very much. Have a very nice evening.